All right, Chapter 7, Post-Traumatic Stress Disorder. So where did the term PTSD start? Well, first of all, it's defined as psychic trauma that is the result of of experiencing an acute, overwhelming threat in which disequilibrium occurs. It was first defined by Sigmund Freud in about 1917, and he also defined it again in like 1963. It's basically that when the mind kind of loses its ability to control the disorganizing effects of the experience. So it kind of just knocks people off balance. You can think of the fact that in your life you have many kind of psychological anchors, things that kind of keep you from keep you grounded. Well, when a trauma occurs, those anchors are kind of yanked up, and there's no real understanding of how what has happened fits into your life experience that you've currently had. And your mind has a hard time figuring out kind of how and why something has occurred and what it means. And that's when a crisis really happens with PTSD. So kind of the how and the why, we can't figure out why it happened. Some of the immediate and vivid results are re-experiencing of the incident, hyperarousal, which means like sort of jumpy, easily irritated, avoidance reactions, trying to stay inside, maybe social phobia. And basically, the event propels the individual into a traumatic state that lasts as long as the mind needs it to in order to reorganize, classify, and make sense of the traumatic experience. Most people are extremely resilient and will quickly return to a state of mental and physical homeostasis. However, after something traumatic happens, if symptoms continue for a minimum of 2 days and a maximum of 4 weeks, and occurs within that 1 month of the traumatic event, then that meets the criteria for acute stress disorder as a diagnosis. If acute stress disorder symptoms develop, they'll typically drop off 1 to 3 months, in 1 to 3 months for most people. If a person can effectively integrate the trauma into their conscious awareness, in other words, if you can realize when you start having flashbacks that that's something that happened in the past and not the present, and the person is able to organize it, then homeostasis can return. If the problem is coped with, again, then the individual can kind of move on. If the event is not effectively integrated or is submerged from awareness, then the probability is high that the initiating stressor will continue to assail the person and it will become chronic PTSD. So it's that reliving of the trauma that causes post-traumatic stress disorder. So there were kind of so 1980 is when PTSD kind of found its way into the third edition of the DSM, which is the Diagnostic and Statistics Manual of Mental Disorders. So 1980 was officially when it was, the diagnosis was kind of born. However, medical professionals started realizing that there was something along that line between the 19th and early 20th century. Two events kind of served as the benchmarks. The first one is there were some railroad accidents that people would have, and these accident survivors had no physical problems, but they had all these symptoms. And so they started calling it railway spine and compensation neurosis because they were invalids, basically, these people who suffered from these railroad accident flashbacks. And the second thing that happened at the same time as those railway accidents was Freud kind of, in his work, created a diagnosis called hysterical neurosis, which he was seeing a bunch of women who were describing sexual abuse in their childhood, and that trauma that was rooted in their life from being sexually abused was kind of sort of something that was manifesting in all these symptoms similar to PTSD. Eventually, his discussion of this caused him to have to disavow his theory and kind of deny that sexual abuse was a thing. So he was kind of the first person to talk about sexual abuse in families, and he was shunned for it and ended up saying he was wrong. And the second thing that happened historically was modern warfare in World War I and World War II, where you start hearing terms like shell shock and combat fatigue, soldier's heart, war neuroses, nostalgia. Those were all disorders. Those were all terms used for disorders to describe soldiers that didn't apparently have any physical wounds, but they were in a mental state that caused them to be debilitated, basically. Vietnam is kind of when PTSD kind of gained more momentum and we kind of started to hear more about post-traumatic stress. In the 80s, what happened is there became a higher recognition of domestic violence and rape. The feminist movement kind of brought into light all these issues around patriarchy and abuse of women, and we saw something called the battered women syndrome used as a defense in cases where women would murder their abusers, and so it became known as, part of a grouping of symptoms. This all came together, like I said, in 1980 for the definition to be really solidified into the Diagnostic and Statistic Manual. So the Diagnostic and Statistic Manual is what social workers, nurses, doctors, psychologists, psychiatrists use to classify mental disorders, mental illness issues. So that's what that is. It's a book that contains all the symptoms and the criteria that people would have to meet in order to receive that diagnosis. So here are the criteria: exposure to a trauma that involves an actual or perceived threat of serious injury or death to self or others, a response to a trauma that was intense with fear, helplessness, or horror, and symptoms arise that were not evident before the event. So they couldn't have these symptoms before. The other criteria is this persistent re-experiencing of the trauma in at least one of the following ways: recurrent or distressing recollections, recurrent nightmares, flashback episodes, distress related to internal and external cues that symbolize the event, and physiological reactions to the event that symbolize the trauma. The behaviors that somebody would manifest have to be consistent with at least 3 of these criteria. They have to persistently avoid the thoughts, the dialogues, or the feelings, persistently avoid related activities, people, or situations, have an inability to recall important details of the trauma, have markedly diminished interest in significant activities, emotionally be detached from others, restricted range of affect, and a sense of a foreshortened future. These are also nervous system arousal symptoms. They're persistent, and then they were not present prior to the trauma. And at least 2 of these following things have to be met in order to get the diagnosis: difficulty falling or staying asleep, irritability or outbursts of anger, difficulty concentrating, hypervigilance, exaggerated startle reactions to minimal stimuli, so basically a reaction that doesn't match what's going on. And the disturbance causes clinically significant impairment to social, occupational, or other critical areas of living. So this significantly impacts the ability of this individual to be able to live their life productively. PTSD in children. There's a bus kidnapping story that takes place in a text that you can read about. It talks about how, lots of children experience at least one traumatic event. Doesn't necessarily mean they'll all develop PTSD. And then below you see the types of trauma that will likely impact the developing of PTSD. So they talk about these 2 different types of trauma, trauma 1 and trauma 2. Type 1 trauma is sort of a sudden and distinct experience, traumatic experience, maybe natural disaster, some sort of sudden, maybe a robbery, something like that, a house fire. Number 2 trauma is complex PTSD. It's kind of a persistent and derives from repeated traumatic events. And it has 3 cardinal symptoms: somatization, which is physical ailments; disassociation, which is divisions in the personality; and affect dysregulation, which is changes in impulse control, attention, perception, and significant relationships. So they have physical problems, they have problems in their personality, and then they have this inability to control their behavior. So PTSD has been with us for a long time, and epidemiologists who study populations indicate that a lifetime rate of about 8% can be expected in the general civilian population in the United States. So, in the common course of events, the chance of catching PTSD is pretty small. The average catch it rate for PTSD appears to be about 20% after trauma is experienced. So, only about 20% of people who experience trauma will develop PTSD. It can be higher in adolescents, employees of hazardous occupations, and victims of burns and sexual assault, refugees, combat veterans. But you can see that many of those folks have repeated exposure to trauma. There's a residual impact, which means it can happen even when somebody has excellent coping skills and a positive support system. Still, there can be a delayed response to a trauma. And then the importance of the trauma type. There's a very important distinction between natural and human-made catastrophes. Acts of God create far fewer incidents of PTSD than human-made ones. As an example, the volcanic eruption of Mount St. Helens incident rate of PTSD was very low at 3 or 4%. Human-made acts of trauma create even more incidents of PTSD when the trauma directly affects the social support system of the family. So Holocaust survivors, hostages, rape victims, children of murdered parents, victims of incest, they all have a strong potential for developing PTSD. Survivors of both human-made disasters, such as, there's a breaking of the Buffalo Creek Dam, and commissioned trauma, such as that bus kidnapping, carry very high potential for PTSD. What makes those kind of events really terrible is that they should not have happened, and responsibility for them can be readily assigned, and they clearly violate acceptable standards of moral conduct. And so as a result, there exists in any human-made catastrophe the likelihood of more severe post-traumatic or psychological problems as compared to the natural disasters. Problem is that the line between the two is becoming less clear, and more people look at technology as a means of controlling nature. So if it rains, but the Army Corps of Engineers builds some sort of a dam and opens the floodgates, and when things go wrong, then individuals start looking for culprits to blame and to sue. The book really looks at how Vietnam is kind of the archetype of PTSD, and has very specific sections that I'm not going to read to you. You can just read through the book. But these are kind of the main tenets of what kind of helped us understand Vietnam as the archetype for PTSD. I'm going to let you read through these 10 predisposing variables of PTSD, and I think that makes sense with everything we've already discussed. We've already discussed some of these symptoms, so go ahead and read through these again. Some of the maladaptive patterns that are characteristics of PTSD. There's this death imprint, like a clear vision that you're going to die, and you really feel like you're going to die. Survivor's guilt over surviving or not preventing another person's death, not having been braver, not being able to stop whatever's happened to you, complaining when others have suffered even more. This idea of desensitization, contradictory emotions within the person can lead to hostile, defensive, anxious, or depressive states. Estrangement, feeling that any future relationships will be significantly insignificant compared to the greater scheme of things. And this emotional enmeshment, in other words, emotional fixation with what has happened, and the idea that you just keep re-experiencing it over and over again. So the impact of Iraq and Afghanistan on PTSD studies is that the military realized that they need to put into place more resilience building programs. So they created a comprehensive soldier fitness program that also looked at helping with families, the family members of the soldiers, and the Army's civilian workforce. So how do we treat adults? Assessment is really the number one way, and there's 3 goals. for assessment of PTSD. First, are the symptoms present? And although their presence may seem to be a given, the length of time from onset can mean different symptoms are more pronounced at different times. Secondly, the diagnosis of presenting problems such as drug abuse or variety of personality disorders can mask PTSD unless care is taken to assess for prior trauma. It is highly probable that people in crisis will present with comorbid problems, which means they could have PTSD and drug or alcohol abuse, or depression and PTSD. PTSD may not be identified as an undergirding problem unless care is taken in assessing for traumatic incidents. So the third thing is there are contextual differences in terms of physical, temporal, social, or political climate. So these variables can have a great deal to do with how the event is interpreted. So was it something in the media? Was it something that they see as normal? So it's really important to understand the contextual variables. So example would be that they give in the book, a Vietnam veteran with PTSD in the 1970s would be perceived as a crazed baby killer, as opposed to the Gulf War, Afghanistan, or Iraq veteran in the 2000s, who would be viewed as with compassion because of the dramatic change in the political climate and the social view of men and women who fought in these wars. Likewise, domestic violence, which was formerly seen as a private matter between husband and wife, is now viewed as a societal ill to the extent that the label battered woman syndrome has been attached to it. So how do we assess for them? For PTSD, there's two major categories, either the structured or the semi-structured interview with empirically derived measures. So in a structured interview, there is a clinician-administered PTSD scale, and this scale looks for 8 associated symptoms: guilt over acts committed or omitted, survivor's guilt, homicidality, however you want to say it, disillusionment with authority, feelings of hopelessness, memory impairment, sadness, depression, and feelings of being overwhelmed. It also examines the impact of symptoms on social and occupational functioning. Improvement in PTSD symptoms since the previous CAPS-1 assessment has really taken place. So it's easier to understand kind of what their symptoms are with the use of this clinical scale. There's also self-reports that look at, there's a traumagram questionnaire, and in your book on page 166, you'll see a traumagram, an example of a traumagram, and you can look through the different events that are in there and kind of try to decide what fell where. And then there are empirically derived scales, MMPI 1, MMPI 2, all look for post-traumatic stress disorders. Those are personality assessments. And then just kind of looking at the overall overview of all the different types of assessment. So how does somebody recover from post-traumatic stress disorder? Number one, you'll see the phases, and on page 169, I'm just going to let you read through all the different phases and kind of how it kind of progresses through treatment. Sometimes initiating treatment or intervention can be very difficult because victims can refuse early intervention. They think they should be able to handle it themselves. They think they should be able to put it in the past. It's too difficult to talk about. So the importance of acceptance cannot really be stressed enough. You know, there's a lot of negative and conflicting emotional baggage that they bring into a session with a helper. So really having an open mind and accepting the client's story can be really difficult, especially if the story involves, you know, some of their moral actions that you may disagree with. So it's very important that you can really understand that you have to work together with the client. Disclosure is really difficult because the events may be horrifying and socially unacceptable, like I said, in the case of a veteran particularly. Often when you are in therapy working through issues with post-traumatic stress, it takes time. This isn't something that's going to be resolved in a really quick period of time. There's just no magical cure. It's very intense treatment, and it can impact the person you're working with's occupation or their relationships. really trying to relieve the psychic pain and relive it. It can get you generally. When I was a therapist, I would tell people it's probably going to get worse before it gets better. Trying to face these really hard things that you've tried to avoid for a really long time is very difficult, and it's a very hard work. Re-experiencing traumatic events is very painful. It's difficult to give up thoughts of revenge related to the trauma. There's pain associated with accepting the world as it is, knowing that it's a kind of bad world sometimes and bad things happen to people. And it's difficult to accept one's own limitations. People feel like they should be able to fix themselves. And so there's a sense of failure if they have to go get help. So there's more rules than that. Also, on page 170, there's a whole bunch of rules that are that can be adapted to kind of help understand what your role is and what the role of the person that you're helping should be. Okay. Oh, there's lots of multiphasic and multimodal treatments. I think group therapy is really great. It lets people hear other people's stories, especially with veterans. It can be very powerful. Sometimes you use behavioral, cognitive behavioral, humanistic, or emotion-focused therapy. And then there's no fixed pharmaceutical regimen that results. Everything kind of varies per person. So there's no medication. There's no miracle cure for post-traumatic stress disorder. It can just take some time.